Can you hear me now? Oh yes, I can't hear myself. But then for me, I feel like it's a privilege to open this weekend's meeting with this very progressive topic, I would say. I'm not here to talk about the use of ultrasound to check for fetal viability. I'm here to kind of bring Tulio's work to an early stage of labor, to the first stage of labor. Can we use ultrasound during the first stage of labor so we can monitor labor progress? So for the last 8 years, I've been reflecting on this assessment of labor progress. Is it time for change? Of course I believe it is. Hopefully I can convince you. Are you all obstetricians here? No one's nodding. Oh my God. Yes, you can't hear me?
Yeah.
Can you hear me? No? Hello? Yes, sorry. All right. If I look at medicine, cardiologists, they used to palpate for thrills, and now they're so ready to bring out their handheld ultrasound device to do a maternal echo. And then neurologists, they have all these old equipment and now so ready to order a brain MRI. How about us, obstetricians? Are we still using our fingers, pinots, sonicates? What is there out there that we can use to help with assessment of labor progress? Of course, for me, is the use of ultrasound. Let's review what we have, what tools we have. Limitations of hologram. I want to highlight this. This is something that we've been using for years. We accept it, but it is good. Is it good? It is not good because we don't actually know the effectiveness of hologram in predicting labor progress. And we know that cervical dilatation assessment is imprecise. What I mean by that is that we don't like 0, we don't like 1, 3, 5, 7, 9, and we love 0, 2, 4, 6, 8, and 10. What I mean is that we have a digital preference, and there's a lot of guessing there. And if you tell laboring women that actually we are guessing the labor progress, I think they would not agree for you to actually examine them digitally because it's so painful. And then in relation to cervical dilatation assessment, we don't know when we should actually do it. We accept that we do it 4 hourly. In my unit now, we do it 2 hourly. And so there is, unstandardized practice. I was referring to the fact that digital examination is intrusive and uncomfortable. But for me, what's more is that it is subjective. It has a high intra-observer variability. It has a very limited value for predicting time and mode of delivery. It can also provoke preterm labor, introduce infection, and findings cannot be reported. And this is a medical legal issue. There's a lot of guessing, as I was referring to. If you're the laboring woman, if I tell you that I'm actually guessing what I'm feeling, I think you would not allow me to stick my fingers up and then cause a lot of discomfort. So I think from my perspective is that we need to bring about an objective process in evaluating labor progress. What's more, of course, we can identify precisely fetal position, you heard from Tulio, and we can also look at the degree of caput. No guessing, is it plus or 2 plus or 3 plus? We can determine how low the fetal head is. Now we know that we can predict the progress during the second stage of labor and predict mode of delivery. And then in my work, we can predict the outcome of labor following induction of labor. So here, I just want to kind of bring it to you, what else we can do with an intrapartum ultrasound. Other than fetal heart activities, fetal line, presentation, and on the top left, there is how we scan for fetal line. Follow the head and the spine. Top right, you can then refer to, that is actually how low the head is in relation to the pubic symphysis. I don't know whether you can see, I don't have a pointer. So we can have a pointer, that would be great. And then top right is basically us finding the pubic bone and then the fetal head, and this is a parasocial view. Then this is actually telling you how low the fetal head is in relation to the pubic symphysis. And the bottom left basically shows you the degree of caput. Can you see the caput, the swelling on the head? And I don't know, there, yes, and the molding. In the old days, we were like, oh, is it a bit of molding or is it a lot of molding? And then on the bottom right, you can definitely see the cervical dilatation as well. Now I talk about the fact that ultrasound is our eyes and ears, as well as our fingers. So I think we can really see. This is cervical dilatation. You can see the caput, you can see the molding. This is the pubic bone I was referring to, and you can see how low the head is. So here, is a comparison between physical and ultrasound examination for assessing progress in labor. I don't want to dwell on this slide, but what I want to highlight is that we can actually convert everything that we do clinically into an ultrasound assessment. But you may say to me, we are going to de-skill. We might not be able to actually feel for the size of the fetus. Honestly, for the last 20 odd years, I haven't actually used my hands to estimate the fetal size. I would go for a more objective assessment because I have the skills to do an ultrasound. But then on the right, you can see that we can really scan for head presentation, position, whether the occiput is posterior. We can also look at station, fetal head, how low the head is by using two tools that Tulio's just mentioned, angle progression and head to perineum distance. And I would challenge you that we can also look at cervical dilatation on transperineal scan, not a transvaginal scan, because I want to limit the number of number of internal examinations and reduce the degree of discomfort and the degree of caput, as I mentioned. No guessing. I want us to stop guessing. I want us to really move away from producing a very wishy-washy report, and then we can then document accurately the labor progression. So I know you've seen these before, and just to remind you how we measure angle progression, why do I choose very simple 2D? It's because 2D ultrasound. I want every healthcare professional on the labor ward providing care for laboring women to be able to do this. So if I say I use very fancy 3D ultrasound, they would say no to me. We are in the process of training all our midwives to do this, and then I'm sure some of the units, people who are really advocating for ultrasound in labor, and they are also teaching many midwives. And I think this is important for us to pick up on in terms of assessing how low the head is. Angle progression is really, for me, a very simple tool. You can see that this is a parasagittal view. Why do I go for the parasagittal pubic bone instead of the pubic symphysis? Is because pubic symphysis is a cartilage. If I were to train midwives to look for the cartilage, it might be much harder. And so now I say slightly off and slightly off. We can look at the pubic bone, which is bright, simple, and then this is one straight line, and then they can identify this, and they can identify the fetal skull, and then they can actually then put a ruler and measure angle progression. So how do we find it? So it's a transperineal scan. You put a glove over the transducer, nothing expensive, okay? You don't need a special cover, you should put a glove on. And then you do the scan, and here you can see, you look for the parasagittal pubic bone, and then you look at the fetal skull. You can already appreciate the caput already. Once you get that very clear image of the parasagittal pubic bone and then the fetal skull, you freeze the image, and then you basically measure the angle progression. Very simple. And then we have seen evidence suggesting that angle progression correlates with fetal head station. However, we have to acknowledge that fetal head station is also a bit of guesswork, right? Where's the spine? Am I guessing? It's more or less like here. But then, so I think you would say that R-squared isn't fantastic, but then our tools that we have are not fantastic. So I would have to accept that. The way we assess for fetal head station is also a bit wishy-washy. And then so hopefully we can go for objective assessment. What is more is that is highly reproducible. And one number I want you to remember is 120 degrees. 120 degrees means that if the angle progression is exceeding 120 degrees, then the chance of successful vaginal delivery is high. Why do I say this? It's because imagine you're on the labor ward. You have to attend to shoulder dystocia, emergency, and then you've got bradycardia, fully dilated. And then I do this assessment, 120 degrees, 130 degrees. I hand over this Form 2 delivery to my junior, and then I go and assess for shoulder dystocia. This is how I can use ultrasound to help me triage my cases on the labor ward. And of course, it will also help you in relation to training, because, well, if my trainee is examining the woman and she says, oh, it's spine, at spine, then I'll do an ultrasound. Then I will see how low the fetal head is. And then another tool that Tulio has already introduced, which is the head to perineum distance. Basically, you rotate the transducer 90 degrees so that it's transverse, and you press on the perineum until you cannot press anymore. You find the shortest distance between the perineum and the fetal head, as you can see with this image. This is the outer, which is the perineum, this is the fetal head. You find the shortest distance, so you can measure this head to perineum distance. So how do we find it? Very simple, as I mentioned. You basically rotate your transducer, and then this video just shows you how much you press on until you cannot press anymore without causing discomfort. And you can also refer to the image on the video on the right. You can actually just about see the cervical dilatation, and the head is above it. And then once you find the shortest distance between the head and the perineum, you freeze the image and measure the head to perineum distance. So the second number I want you to remember is 4.5 centimeters pre-labor. So if the head to perineum distance is less than 4.5 centimeters, then the chance of a successful vaginal delivery is high. And this number goes down to 3.5 centimeters in labor. So that has already been published. I mean, actually, this is not something new. Agable has already talked about this for years, and then I'm really, really excited to be bringing this to clinical practice. The third ultrasound parameter is cervical dilatation. So while you have the transducer in the transverse plane, then you can then dip and tilt your transducer to find the ring, as you can see. You basically measure the anterior-posterior diameter, and this is how you do it. Very simple, perhaps too simple. And then another way of finding it is that you basically start with the sagittal plane, you find the cervix, and you rotate on the cervix. So you can see this is the ring, and you find a very well-defined cervical ring, and you freeze the image and you measure the anterior-posterior diameter. So sounds very simple, and then it takes a little bit of time to master these. However, the learning curve, I would say, is about 20 scans. Sonopallogram, I don't think this is something new. It was kind of introduced about 10 years ago. We're still talking about it. We would love to integrate the use of ultrasound in a routine pallogram. And this is a very interesting study talking about feasibility. And the key of this study is just to say that actually with sonopallogram, the successful completion of the pallogram was much higher at 95% compared to vaginal examination at 82%, and that the cervical dilatation showed a positive correlation with between vaginal examination and ultrasound, and the head descent also was showing some degree of correlation. But then I think that was the beginning of the journey, because I got to know about it in 2015. So I then brought it to my unit, and then I did a first of all, validation study. What I mean by validation study was that I had two teams. I had an ultrasound team, I had a labor team, and the labor team was not talking to the ultrasound team. So every time the labor team was doing a vaginal examination, the ultrasound team would go and do the ultrasound, and they were not talking. Basically, we created this table. So we were able to correlate the fetal head station with angle progression as well as head to perineum distance. And this is extremely important, because if I say to my team, now you need to stop doing vaginal examination, you need to start using ultrasound, and then they can refer to this table. Okay, they can measure angle progression is 95 degrees and it's -3. They can document this and they can refer to this publication, and so that they felt like there's something that they can refer to. They're not creating, they're not causing risks. So this is what we did initially, and then we did an implementation study of using the sonopallogram, and we did a multi-center feasibility study, and across 3 units in Hong Kong and Spain, and we recruited women with single pregnancy, cephalic presentation for induction labor. The baseline scan was an abdominal scan and a transperineal scan assessing fetal size, fetal Dopplers, amniotic fluid index, and fetal spine and occiput positions, and cervical dilatation, length, angle progression, head to perineum distance, and inch-palm scans were performed instead of vaginal examinations. Well, in my unit, it was every 2 hourly we did a vaginal examination, so instead of that we did the scan, and in other units they were doing according to the local protocol. So every vaginal examination we tried our best to avoid doing it, and then we repeated the fetal spine, occiput positions, and progression, head to perineum distance, and cervical dilatation. We also evaluated pain for those who did not have an epidural. And then we recruited 100 patients, and 20 needed cesarean section, 80 had a vaginal delivery. Altogether, we did 223 inch-palm ultrasound scans with a median of 2 per participant. 151 vaginal examinations with a median of 1 per participant. We did not cause any harm to the mother nor the baby, and the median pain score was 0 for intrapalm ultrasound and 3 for vaginal examination. Actually, I was so surprised that our women were so tolerant of vaginal examination. And then what we found was that cesarean section and epidural were significantly associated with slow rate of change in the angle progression, head-to-pelvic distance, and cervical dilatation. On the right, you can see the angle progression graph. And then the blue line is good, vaginal delivery, and you can see the beautiful progression of angle progression per scan. And then the red line was the cesarean section group. And on the left, you see the head-to-perineum distance. It seems that, head-to-perineum distance is really helpful at the beginning of labor to differentiate those who would have a successful vaginal delivery versus not. And that progress doesn't actually change. The rate of change is more or less the same, and the separation is parallel. And as for cervical dilatation, you can see the vaginal delivery group showing progress, whereas the cesarean section group didn't show progress. And what is important for you to recognize that beyond 6 or 7 centimeters, it was much harder to actually scan for the cervical dilatation. So in our clinical practice, in our feasibility study, we advise that if you could not see the cervix on scan, then you can do a vaginal examination. And you should do a vaginal examination when there's bradycardia, when there's antepartum hemorrhage, etc. So that was the safety net that we put in place. So just want to give you an idea. I hope you can see. Now they dim the light. I hope you were able to see the videos. This is one case, real case. A 33-year-old woman, first pregnancy, 41 weeks for induction labor. And at 412, you can see the angle progression 119 degrees, pretty good, yes? And 1 degree short of 120, head-to-perineum distance was 5.7 centimeters, cervical dilatation was 1.56, I hope you can see, it's just about here. And then a few hours later, following that, we did an artificial rupture membranes because her cervix was favorable, and then there was progressive angle progression, and then not so much with the head-to-perineum distance. And the cervical dilatation got to 4.85 centimeters, and then past midnight, not much progress, and then we increased the syntone. And then several hours later, angle progression got to 143 degrees, head-to-perineum distance 3.7 centimeters. We're not able to visualize the cervical dilatation. And then actually, she got to fully, as expected. She had a vaginal delivery at 4:19. We avoided 3 vaginal examinations. You may say, oh, that's nothing. But actually, I would say that, we didn't cause pain, we didn't cause high risk of infection, and so for me, it was a success. So we're working on creating a solid parallelogram. This is a traditional parallelogram on the left, and we are creating the boxes to document all the ultrasound parameters during labor. So to finish off, I want to say that, as I mentioned, we only want to introduce 2D ultrasound for this because we would like to train all healthcare professionals taking care of laboring women. This is the work of my Spanish colleagues, and they did a competition between midwives and obstetricians. I mean, I talk about competition, but ultimately I'm really hoping for collaboration. And this is because we wanted to promote the use of ultrasound by the midwives. And then they did a head-to-head comparison. So one obstetrician did a scan versus one midwife doing the scan. They were blinded to each other's ultrasound findings, and then they did various ultrasound parameters, as you can see, fetal head position, angle progression, head-to-perineum distance, as well as cervical dilatation. The midwives were not phased by us asking them to do cervical dilatation. So just some simple results. On the left, you got the angle progression, the difference between doctors and midwives, 2.5 degrees. In the middle, cervical head-to-perineum distance, the difference between the doctors and midwives, 0.04 centimeter. On the right, and the difference between the doctors and midwives in measuring cervical dilatation was 0.16 centimeter. What is more is the ICC. Basically just a strong relationship between the two groups, and the most important thing is actually the ICC for cervical dilatation. The agreement between the two groups was very, very good, 0.94. So actually, we are able to prove that we can train a novice in doing labor ultrasound. And then they did not have any prior experience, and I mentioned that the learning curve is about 20 cases. So this is my checklist now for intrapalmar scan, spine position, angle progression, head-to-perineum distance, plus minus cervical dilatation on scan, caput, and molding. So this is my dream. in the modern maternity room, that every room would have an ultrasound machine whereby then we can be ready to evaluate fetal heart activities as well as evaluate labor progression. Thank you very much for your attention.